So in this video, we'll learn about ocular examination. So in this video, I only cover about eyebrows and eyelids. What are the things that you look for and what is normal and what is abnormal? First, let's learn about eyebrows. So the first thing you look about in eyebrows is position. What is the position? The normal position is normally the eyebrow lies over the orbital rim in males and a few millimeters below above the rim in females. Now, if it is below the rim, it is abnormal for both genders, and it might be a reason it is called as brotosis. Okay, the normal shape, it is arched with concavity downwards and has a sloping tip. Okay, and this can also be altered in cases of trauma or cavity is usually downwards, but it might not be arched upwards. So it might be a straight line or flat downwards in brotosis. What is madarosis? Madarosis is loss of eyebrow hair. Okay, so either it could be loss of eyebrow hair in the lateral aspect or in the medial aspect. So what are the causes? In the lateral one third, if it is lost, it's usually seen in leprosy, and in medial one third, it is lost in case of myxedema. These are the systemic causes, but there can be local causes also for loss of eyebrow hair, and these could be trauma or infections. Okay, over the lid folliculitis over the eyebrows, like folliculitis can cause mudrosis. Now coming to Hertog sign or Queen Anne sign. Okay, this was defined as loss of lateral one third of eyebrows. We already learned leprosy is one of the causes. So, but other causes are leprosy, follicular mucinosis, trichotillomania, where they pull out the hair follicles, ectodermal dysplasia, DLE, systemic sclerosis, and alopecia areata. But the most common cause is leprosy and is also called as Queen Anne sign or Hertog sign. Now coming to eyelids, once the eyebrows examination is done, we'll talk about eyelids. The position of the eyelids. Okay, normally the upper eyelid covers about 2 millimeter of the superior cornea and the lower eyelid just touches the limbus. Now, in the upper limbus, superior limbus is visible, or that's otherwise called as staring sign or scleral show. There's a sclera is seen above the superior limbus. This is also called as scleral show, most commonly seen in thyrotoxicosis or sympathetic overactivity. If the lower lid droops more than 2 millimeter, otherwise called as ptosis, okay, blepharotosis, causes can be congenital or involutional or cicatricial trauma or nerve palsies. So it can be anything. Okay, it's also called as blepharotosis. The palpebral fissure height. First, we need to know what is a normal palpebral fissure height, and then we can comment about the abnormal fissure heights. The normal fissure height is vertically it's around 10 to 12 millimeters, and horizontally it is around 28 to 30 millimeters. Obviously, this will change when in different races too. Now, when the horizontal diameter is reduced, okay, it is called as ankyloblepharon. Now, coming to movements of the eyelids, these are things that you will observe. The normal blink rate is around 12 to 16 blinks per minute. Now, if it is reduced, the blink rate is reduced in cases of trigeminal anesthesia and facial nerve palsy. It is increased in dry eye. Okay, so these also you can make out by looking at the eyelids. Now, what else you look? Lag of thalamus, that is inability to close the eyelids. Okay, where do you see? So, what is the muscle which helps to close the eyelids? Is orbicularis oculi. So, if there's paralysis of orbicularis oculi, or now that is the nerve supplying the orbicularis oculi, that is the facial nerve, you will have facial nerve paralysis. So, which is the commonest symptom or sign of facial nerve paralysis is inability to close the eyelids, otherwise called as lag of thalamus. So where else do you see lag of thalamus, inability to close the eye? One is facial nerve palsy, but you can also see in severe proptosis or symblepharon. Okay. So there is inability to close the eyelids in case of the right eye. That's what you see in lag of thalamus. Now, what else you see? Lid margin. Once you see the gross examination of the position, the the palpebral fissure, the movements. Then you'll go on to examining the lid margin. What is entropion? It is an inturned eyelid margin. You see that the lid margin is not lying against the ocular surface, it is interned and the eyelashes are rubbing against the ocular surface of the cornea. The causes can be senile, cicatricial, congenital, or mechanical. Mechanical in terms when there's a tumor or pulling on or pressing on to the causing an entropion. Ectropion. What is ectropion? So first one is entropion, interned eyelid margin. Second one, it could be outturned eyelid margin, otherwise called as ectropion. You see that here the eyelid margins turned out and you can see the palpebral conjunctiva also here. This is ectropion. Again, the causes can be senile, cicatricial, congenital, and mechanical. We'll learn about these things in another video. Then eyelash, once you see the margins of the eyelid, then you'll see the eyelash abnormalities. What are the abnormalities that you can see in eyelashes? Okay, trichiasis or otherwise called as misdirected cilia. Here if you see, the lid margin is well opposed, but if you see here, one eyelash is misdirected and it is touching the cornea. So normally the lower lid eyelashes are directed forwards, back and backwards, right? Forwards, downwards, and backwards. The upper lid eyelashes are directed forwards, upwards, and backwards. But here the eyelash is directed backwards, right? So this is a misdirected cilia, otherwise called as trichiasis. Just a minute. So normal eyelash is directed forwards and upwards and backwards, whereas here it is misdirected and it can cause abnormalities. The causes could be blepharitis, trachoma, lid trauma, or a stye. Recurrent styes can also cause trichiasis. What is dystrichiasis? Abnormal extra row of eyelashes. So this one is not an extra row of eyelashes. It's just one eyelash which is misdirected. Whereas dystrichiasis or distichiasis is abnormal extra row of eyelashes. So normally eyelashes in the eyelid come from the are in front of the gray line. They're not behind the gray line. But if they are seen behind the gray line, we call it as dystichiasis. Usually they don't arise from the meibomian gland orifices, but here in dystichiasis they arise from the meibomian gland orifices. Okay. Now, what else will you see in the eyelid margin? Metarosis. What we saw in eyebrow, we can see in eyelid margin also. There is loss or absence of cilia, which can be seen in leprosy, chronic blepharitis, or mixed edema. So, what you see here? So, you see that there is loss of eyelashes. So, it could be a particular blepharitis or a recurrent infection in that particular part will cause loss of eyelashes. Then poliosis. What is poliosis? This is graying of cilia. So where do you see graying of cilia? Obviously, old age, you will see graying of cilia, but graying of eyelash cilia occurs after 70 years, okay? Not before that. Old age, Koyanagi-Harada disease, you can see in even in 30 or 40 years of age, when you see poliosis, you have to suspect this disease. Now, tylosis is rounding of the lid margin. Normally, the eyelid margin is sharp. Posterior eyelid margin is sharp. But here, you see that this margin is rounded up. So, again, this is called as tylosis. Causes chronic blepharitis, leads to rounding up of the lid margin. Now, eyelid, once you've done with eyelid margin, you can appreciate the swellings. If there are swellings, you will see the swellings in lid margin, which can be acute, chronic, or acute or chronic inflammatory or chronic neoplastic. Okay. In acute cases, they'll be red. You will see a pus pointing. It can be either internal hordeolum, which is a meibomian gland inflammation, or it can be a cyst of Zeiss associated with the eyelashes. So that is an external hordeolum. Or it can be a chronic granulomatous inflammation of the meibomian gland, which is seen in as chalazion, or it can be a neoplastic condition where you see sebaceous gland carcinoma or squamous cell carcinoma. Of course, you have to look for the abnormalities, and if you don't see, you don't write it. You'll say it is normal, right? Then coming to the palpebral aperture, I've already told that the vertical margin, lid margin height is around 10 to 12 and horizontal is around 28 to 30. Now, what is ankyloblepharon? But you can see reduction in the palpebral aperture in two conditions, that is ankyloblepharon and blepharophimosis. What is ankyloblepharon? Horizontally, it's a narrow palpebral fissure. So vertically, it might be still be 10 to 12, but horizontally, it is reduced. Where do you see it? You see it usually in ulcerative blepharitis. Blepharophimosis is a condition where the palpebral fissure is reduced both vertically and horizontally. It's not only horizontally, it's reduced both in vertically and horizontally. This is usually seen as congenital blepharophimosis syndrome. Okay. Now, vertically narrow palpebral fissure and vertically wide palpebral fissure. Okay. So where do you see? What are the two conditions that you will appreciate in palpebral fissure? One, it's either narrow and one, it is wide. Where you see in vertically narrow palpebral fissure? In ptosis. In ophthalmos, when the eyeball is gone inside. Okay, not exophthalmos, inside. It has gone inside, then the lid appears drooping down. And ophthalmos, when there's no eyeball at all. Okay, microphthalmos, when the eyeball is small, then also it will appear that there's a palpebral fissure is small. Phthisis bulbi or trophic bulbi, where the eyeball is distorted or it is shrunk. Now, the size is shrunk, then that is an atrophic bulbi. Also, we'll see that the palpebral fissure height is reduced compared to the normal height is reduced. Now, where do you see vertically wide palpebral fissure? In proptosis, when the eyeball is protruding forwards. Large size of the eyeball. When you see unilateral myopia, you see that the eyeball is appears larger and the palpebral fissure is also increased. Or when there is retraction of the upper lid, in case of facial nerve palsy or in case of thyrotoxicosis, you can see retraction of the upper lid and see a wide palpebral fissure. So in summary, when you're examining the eyebrows and eyelids, for eyebrows, you will look for the shape, the position, and loss of eyelashes, metarosis present or not. If it is normal, you'll just write eyebrows normal. You'll not say shape, position, normal, no metarosis or anything like that. So if everything is normal, describe as normal. Eyelids, again, you'll look at the shape, position, and the margin. Then if you don't find any abnormality, describe as normal. Then you look for any margin abnormalities like loss of eyelashes, trichiasis, scoliosis, or any swellings present. You'll also look for the palpebral fissure height. If it is normal, you will say it is normal only. If it is abnormal, you'll mention it. Otherwise, you will describe it as normal. Okay, please do not write no madarosis, no trichiasis, or all those things. Only if you find them, you will write them. Okay, when you find everything is normal, you just write eyebrows and eyelids normal and move on to the next examination.